Welcome to the Deep Dive. Today, our mission is really to cut through some pretty complex source material. We want to give you the core knowledge you need, fast. We're diving into musculoskeletal tumors specifically, bone and soft tissue sarcomas. And this is tough territory. Why? Because, as our sources highlight, sarcomas make up less than 1% of all new cancer diagnoses. They're rarity. It often means diagnosis gets delayed. So we're here to provide sort of the cheat sheet, the key patterns, those crucial diagnostic red flags, and the management strategies that really matter for survival.
And that specialized focus is absolutely necessary because these lesions, whether they turn out to be benign, intermediate, or malignant, they often look confusingly similar clinically on scans, even under the microscope, so they're always considered together. And this really demands that diagnosis and definitely management happens only in specialist multidisciplinary centers.
Right. That urgency is clear. Okay, let's start with the numbers. Understanding just how rare these are is maybe the first step to keeping that high index of suspicion. What's the comparison? Bone versus soft tissue sarcomas frequency-wise.
It's quite a contrast, actually. Bone sarcomas, in places like the UK, for example, are incredibly rare. We're talking just 0.2% of all new cancers. That translates to about 8.2 cases per million people per year.
Wow, really uncommon.
Exactly. Now, soft tissue sarcomas are, well, substantially more frequent, around 45 cases per million. Still rare in the big picture, but that's nearly a six-fold difference between the two.
And the demographics tell a story, too. For soft tissue sarcomas, incidence tends to climb with age, right? Peaking in older men.
That's generally true, yes. Highest rates often seen in males over 85. But bone sarcomas, they're different. They show this pattern that should really make any clinician pause.
Ah, you mean the bimodal distribution.
That's the crucial bit, yes, the bimodal distribution. You see one peak in incidence during the teenage and adolescent years, and then there's a second later peak in the elderly population.
That pattern itself is a warning sign, isn't it? Especially if you're seeing a younger person with ongoing pain that maybe gets brushed off as just growing pains.
Precisely. Dismissing it can be dangerous.
And what really drives home the need for specialization here is the genetics. These aren't just random occurrences. They often stem from very specific molecular mistakes. Let's take osteosarcoma, the most common primary malignant bone tumor. Our sources say, 70% of those cases have clear molecular signatures?
Exactly. You see specific mutations, often in DNA helices or really important tumor suppressor genes, like the p53 gene mutation, which you often see linked with Li-Fraumeni syndrome, or mutations in the RB1 gene associated with retinoblastoma.
So inherited syndromes can significantly bump up the risk.
These certainly can, and that molecular picture is even sharper with Ewing sarcoma, isn't it?
Almost perfectly defined, it seems.
It's practically universal there. Over 95% of Ewing's tumors show that specific EWS-ETS fusion gene rearrangement. Usually it's from a translocation, a swap between chromosome 22 and chromosome 11.
And knowing these drivers isn't just academic. It points toward diagnosis and potentially future treatments.
Absolutely. It informs diagnosis, prognosis, and research into targeted therapies. It also ties into location. Over 60% of these primary bone tumors pop up in the long bones of the lower limb, especially around the knee.
Okay, so given that peak in teenagers and the fact that symptoms can easily be confused with, say, a sports injury, let's talk clinical presentation. The huge challenge here seems to be avoiding delayed diagnosis. What are those absolute red flags that mean a physician has to dig deeper?
Well, the most common thing people come in with is pain. Often starts mild, maybe intermittent, but then it tends to get relentlessly worse. But the single symptom that should trigger immediate alarm bells is night pain. Pain that actually wakes the patient from sleep, regardless of what they did that day. That's a big one.
Night pain. Got it. What else?
Other things to watch for are pain that just hangs around after a really minor injury or maybe doesn't seem proportional to the injury, or pain that simply doesn't get better with standard over-the-counter painkillers like paracetamol or ibuprofen.
Okay. And soft tissue sarcomas, they often present differently, don't they? Usually more like a painless lump.
That's right. The majority present as a painless, enlarging mass, which can make them seem less urgent initially.
So what's the rule of thumb? The clinical threshold we have to remember when assessing any lump?
You need a clear triage rule. For soft tissue lesions, it's this. Any superficial lump, one you can easily feel under the skin, that's bigger than 5 centimeters, or any lesion that's deep-seated, meaning below the fascia, regardless of its size. You must treat it as a sarcoma until you've definitively proven it's benign. Size and depth are the immediate, non-negotiable flags.
Okay, that's a clear guideline. So suspicion is high. The investigation usually starts with the simplest tool, The X-ray. When someone's looking at a potentially suspicious X-ray, what are the key questions running through their mind to gauge how aggressive this thing might be?
You need to characterize it quickly. First, location, location, location. Is it in the shaft of the bone, the diaphysis,
Yeah.
or near the growth plate area, the metaphysis, or at the very end, near the joint, the epiphysis? Just knowing the location drastically narrows down the possibilities.
Okay, location first, then what?
Then, what's the lesion actually doing to the bone? Is it eating it away? Is it zolytic? Is it causing new bone to form? Is it sclerotic? Or is it a mix? Also, how sharp are the borders? Is it well-defined, or does it look like it's infiltrating aggressively? And is there any reaction from the periosteum, the lining of the bone?
Right. Those features guide the next steps, and that usually means moving to more advanced imaging for staging. Why is CT so crucial for systemic staging?
It comes down to how these tumors spread. Most bone and soft tissue sarcomas, they metastasize through the bloodstream hematogenously. And the lungs are like the first filter, so they're the most common site for distant spread. CT scans, computed tomography are just the best tool we have for picking up those small pulmonary metastases. It's essential.
Okay, CT for the lungs, and MRI then gives you the local picture.
Precisely. MRI, magnetic resonance imaging, defines the local battleground. It's absolutely critical for planning surgery, especially if you're aiming for limb salvage. It shows the tumor's exact relationship to nerves and blood vessels, how far it extends within the bone marrow, whether it's broken out of the bone into the soft tissues or even into the joint. All crucial details for deciding the surgical approach.
Before we move on from diagnosis, we absolutely have to mention the mimics, right? Because not everything that looks bad on an X-ray is a tumor.
Oh, absolutely. Misdiagnosis is a real pitfall. Pain in a limb is common, and several conditions can look alarmingly like a tumor on imaging. Things like bone infections, osteomyelitis, or inflammation like myositis ossificans, where bone forms in muscle after trauma.
Even a stress fracture.
Yes, particularly healing stress fracture. The callus, the new bone forming, can sometimes look very similar to an aggressive osteosarcoma on an initial X-ray. So understanding these mimics is just as vital as knowing the tumors themselves.
That naturally leads us to classification. Once you suspect it is a tumor, how do we categorize it? The WHO system seems key based on cell type and behavior.
That's right. The World Health Organization classification is based on the presumed cell of origin, but clinically, it's the behavioral spectrum that guides us most. At the simplest end, you have benign lesions. Think of a non-ossifying fibroma. They're often latent, meaning inactive. They don't invade nearby tissues. They don't spread. Simple surgery is usually curative.
Okay, benign is straightforward. Then it gets more complex with the intermediate category.
Exactly. Intermediate lesions are trickier. There are two main types within this group. First, you have the locally aggressive ones. Osteoblastoma is a good example. These don't typically metastasize, but they can aggressively destroy the surrounding bone and tissue. They often recur locally after surgery, so they might need a more extensive on-block resection.
And block meaning taking it out in one piece with a margin of normal tissue.
Correct. And then there's the second really interesting intermediate group, those that rarely metastasize.
Ah, and that's where the giant cell tumor of bone fits in, the GCT.
Precisely. GCT is the classic example.
Yeah.
It behaves very aggressively locally, just like the first group, but it also carries this small but definite risk of spreading elsewhere, usually to the lungs. Less than 2% risk, but it's there.
And then we get to the clearly malignant tumors. How is their behavior defined?
Malignant means they have the potential for both local invasion and distant metastases. Their behavior, their aggressiveness, is primarily defined by their histological grade. Grade basically reflects how abnormal the cells look under the microscope and how fast they're dividing. For soft tissue sarcomas, we commonly use the FNCLCC grading system.
And that grade makes a huge difference prognostically, doesn't it? High grade versus low grade.
Absolutely massive difference. The high-grade tumors, think osteosarcoma, Ewing sarcoma, they have a very high intrinsic risk of metastasizing. Depending on the stage of diagnosis, that risk can be anywhere from 20% right up to, well, nearly 100% if it's already spread. Whereas a low-grade malignant tumors like periosteal osteosarcoma or chordoma, they tend to grow much more slowly. Metastases are less common initially, but the tricky thing is they can still appear sometimes many years, even decades, after the primary tumor was treated.
Dealing with all that complexity needs robust staging. But why two main systems? Enicking and TNM, doesn't that just kind of complicate things?
It might seem that way, but they actually serve different, though related, critical purposes, especially historically. The classic Enicking system was really developed by orthopedic oncologists for planning limb surgery. It focuses on grade, low-high, whether metastases are present, but crucially whether the tumor is contained within its natural anatomical compartment, like the bone itself, intracompartmental, or if it has broken out extracompartmental.
Yeah.
This directly guided how wide the surgical margin needed to be.
Okay, so Anaking is very surgically focused, whereas the TNM system, that's more like what we see in other cancers.
Yes, exactly. The TNM system, tumor size, regional nodes, distant metastasis, is the more conventional oncology staging system. It's generally favored now, especially for soft tissue sarcomas. It puts more emphasis on tumor size with slightly different cutoffs for bone versus soft tissue, like 5 centimeters being a key threshold for soft tissue, maybe 8 centimeters for bone, along with grade and the presence of metastases.
But ultimately, whichever system you use.
Ultimately, the stage of the disease, however it's defined, is the single most powerful predictor of the patient's prognosis and overall survival chances. Higher stage means tougher fight.
Which brings us squarely to management. And the absolute baseline here is that any suspected malignant or tricky intermediate lesion must be managed by an MDT, that highly skilled, multidisciplinary team.
Non-negotiable. You need orthopedic oncologists, medical oncologists, radiation oncologists, specialist radiologists, pathologists, nurses, everyone on the same page.
And the cornerstone of cure, when possible, is always surgery. Getting the tumor out with the right margins based on those Anaking principles we mentioned.
Yes, the surgical margin is everything for local control. Anaking defined them clearly. You start with intralesional surgery. That means the surgeon actually cuts into the tumor. This is only okay for certain benign lesions where you might do a curettage, scraping it out. For malignancy, absolutely not. It spills tumor cells everywhere.
Right, that makes sense. So the next step up is marginal.
Marginal resection. This means the surgeon dissects right along the edge of the tumor, or its reactive pseudocapsule. This is usually sufficient for most benign tumors and some intermediate ones. But for a true malignancy, even marginal isn't enough. Why? Because there are often microscopic fingers of tumor extending out into that reactive zone just beyond what you can see or feel.
So for cancer, you need to go wider.
That's the standard, wide resection. The entire dissection plane is through completely normal, healthy tissue, well away from the tumor and its reactive zone. That wide margin is what gives you the best chance of removing all the cancer cells locally. It's the definition of oncological safety.
But surgery isn't always the first step, is it? Especially for those high-grade tumors like osteosarcoma and Ewing's that respond to chemotherapy, neoadjuvant therapy comes first.
Yes, preoperative or neoadjuvant therapy, usually chemotherapy for osteosarcoma and Ewing's, is absolutely critical. It serves two main goals. Locally, the aim is to shrink the tumor. This can sometimes make a previously unresectable tumor resectable, or maybe allow for limb-sparing surgery where an amputation might have been the only option otherwise.
Okay, shrinking it locally, what's the other goal?
Systemically, and arguably even more importantly, it treats micrometastatic disease. These are tiny deposits of cancer cells that have already spread, usually to the lungs, but are too small to see on scans yet. Hitting them early with chemo improves survival.
And after the surgery, how do the surgeons and pathologists know if that pre-op chemo actually worked well?
They look very carefully at the removed tumor under the microscope. The key measure is the tumor necrosis rate. What percentage of the tumor cells were killed by the chemotherapy? In osteosarcoma, specifically, getting more than 90% necrosis is defined as a good response. And that's a really powerful indicator of a much better long-term prognosis.
That success in local control directly impacts that really difficult decision. Limb salvage versus amputation.
It does. And the landscape here has changed dramatically over the last few decades. The really important message is that for most patients today, where both options are technically feasible, the long-term survival rates are considered similar, whether they have limb salvage surgery or an amputation.
That's huge. So function and quality of life become bigger factors in the decision.
Exactly. However, the absolute priority must always be achieving that complete, wide, oncologically sound resection. Limb salvage should never compromise the margin. If the tumor is wrapped around major nerves or blood vessels that can't be spared, then amputation, while obviously life-altering, might still be the safer oncological choice to guarantee removal of all the cancer.
But limb salvage is possible more often now.
Oh, much more often. Thanks to better imaging, better chemo shrinking tumors beforehand, and incredible advances in reconstructive surgery using bone grafts, metal implants, or vascularized grafts. Limb salvage is now achievable for around 85% of sarcomas occurring in the arms or legs.
Okay, to really make these concepts stick, let's maybe wrap up by focusing on 3 specific tumor types that highlight some of the key points we've discussed. Maybe starting with a common benign one, Osteoid osteoma.
Good example. Osteoid osteoma is important because of its classic, almost textbook presentation. Patients typically have pain, but it's characteristically worse at night. And here's the clincher, the high-yield fact for you. The pain is often dramatically, almost magically relieved by simple, non-steroidal anti-inflammatories, NSAIDs like ibuprofen.
That NSAID response is the giveaway.
It's a huge clue, and the treatment now is often really neat and minimally invasive, usually CT-guided radiofrequency ablation. They use imaging to guide a needle right into the tumor's core, the nidus, and basically burn it out. Very effective.
Okay, neat. Now, let's shift to a malignant one where the systemic treatment approach is completely different. Chondrosarcoma, second most common primary bone cancer, right?
That's right. And chondrosarcoma highlights a critical point about management diversity. It is fundamentally resistant to both chemotherapy and radiation. Neither works effectively against most types of chondrosarcoma.
So surgery is the only option.
Wide surgical excision is the only potentially curative treatment. Getting clear margins first time is paramount. Another important point is that chondrosarcomas can sometimes arise from pre-existing benign cartilage lesions, like in inherited conditions such as Ollier's disease or Maffucci syndrome. You need to watch those patients closely.
Okay, chemo-resistant, very different from osteosarcoma. Finally, let's circle back to the giant cell tumor, GCT. That intermediate one, locally aggressive, but rarely metastasizing. What's the key learning point there?
GCT is fascinating because understanding its underlying biology has led directly to a targeted therapy. We figured out that GCT growth and the massive bone destruction it causes are driven by osteoclasts, which are switched on by a signaling molecule called rank ligand, or NKL.
So you target RET-GO.
Exactly. This led to the development and use of denosumab, which is a monoclonal antibody that specifically blocks rank-NKL. By blocking rank-NKL, denosumab stops the osteoclasts, halts the bone destruction, often solidifies the bone around the tumor, and can shrink the tumor ikun. It's now used frequently for GCTs that are difficult to resect or have spread, turning a difficult local problem into something much more manageable, sometimes even allowing less aggressive surgery later. It's a great example of targeted therapy in bone oncology.
That's a fantastic example of bench-to-bedside progress. Just before we finish, a quick mention of the elephant in the room, metastatic bone disease.
Yes, critical context. We focused on primary tumors starting in bone, but far, far more common, especially in older adults, is cancer that is spread to the bone from elsewhere, metastatic disease.
And they look different depending on the primary cancer.
Often, yes. Classically, metastases from prostate cancer tend to be bone-forming or sclerotic, making the bone look dense on X-ray, whereas metastases from kidney cancer or thyroid cancer are typically bone-destroying or nihilytic. Recognizing these patterns can sometimes even point towards the original source of the cancer.
Okay, so wrapping this all up, what are the absolute key takeaways for you? We've hit the rarity, the crucial red flags, night pain. The 5-centimeter rule for soft tissue lumps the non-negotiable MDT management.
And that huge difference in chemosensitivity, right?
Yeah.
The contrast between a responsive tumor like osteosarcoma, where chemo is vital, and a resistant one like chondrosarcoma, where surgery is basically everything. But maybe my final thought for you, the listener, is this. Mastering this complex field often starts by avoiding the simplest mistake. Because these conditions are so rare, and because those early symptoms pain, a lump can mimic everyday injuries or benign problems. Diagnosis gets delayed all the time. So it's not just about learning the complex staging systems or surgical techniques. It's equally critical to maintain that high index of suspicion when faced with persistent unexplained symptoms. And to know their mimics, the infections, the stress fractures, just as well as, the sarcomas themselves. That initial suspicion is often the most critical step.
That really brings it home. Knowing the difference between just a nagging ache and something potentially life-threatening could simply come down to asking, is this pain consistently waking you from sleep? Thank you for diving deep with us today.